We might make a start. We are slightly delayed. Apologies for that. It seems like in life the only certainties are death, taxes, and delays on the district line, so we've been victim of that. But thank you all so much for being here today to join us for this event entitled Proactive, Predictive, and Personalised Accelerating the Prevention Revolution. As we all know, as pressures continue to grow on health and care services, and we have a growing recognition that the health challenges facing our country are very different to the ones we've faced in the past. There have been calls for a fundamentally different approach to health and care, and in particular a real pivot towards prevention. And really thankfully there's a huge consensus emerging on both sides of politics and amongst health and care system leaders themselves that is the change of direction that we need to pursue. And fortunately, this time it seems like the rhetoric around prevention is starting to be matched by action. So we've seen a big commitment from government in the last few weeks around smoking. We're seeing huge change in terms of the way in which the health system itself is configured to really prioritise population health. And we've seen Labor put prevention right at the heart of its mission for health in government. But of course, there's still a huge way to go on the prevention agenda. Our system itself, from a governance perspective, is perhaps not as well set up as it should be to prioritise prevention. The funding system and funding model that we have in this country might order against some of the preventative revolution that we want to see, and we're still not making the most of the opportunities that digital data and technology have to really push forward prevention. So, with that in mind, what are the next steps in terms of actually accelerating a prevention revolution? And to discuss that with me today, we have three fantastic speakers. So firstly, we have Steve Bryan, MP. Steve's been the MP for Winchester since 2010. He's currently the chair of the Health Select Committee, or Health and Care Select Committee, should I say, and will soon be celebrating his first anniversary in that role. Yeah. Previously, he was a Minister in Government for Public Health and Primary Care, and he's also the co-host of Prevention. And he's the co-host of the aptly named podcast Prevention is the New Cure. Secondly is the Right Honourable Patricia Hewitt. Patricia was the MP for Leicester West from 1997 to 2010. She was the Secretary of State for Health between 2005 and 2007. And since 2017, she's been the chair of Norfolk and Waveney STP and now ICS. And earlier this year, she published a Government Commission report on integrated care system autonomy and accountability with, as I'm sure everyone knows, a very big focus on the prevention agenda. And finally, we have Rebecca Catterick from Sanofi, who is Sanofi's UK and Ireland General Manager for Vaccines. She spent 25 years in the life sciences sector and has a particular interest in preventative healthcare. So without further ado, I'll pass over to Steve for opening remarks.
Okay, do I need that? You can hear me, can't you? Yeah. All right. Well, thank you for that introduction. Thank you for asking me along. I mean, you're right. I do present a fortnightly podcast which talks about serious issues around prevention. But although I was at the pharmacy show on, it's always the things you don't expect. I was at the pharmacy show on Monday at the NEC in Birmingham and talking about our inquiry into pharmacy. And someone came up to me afterwards and said, "Oh, I do actually listen to the podcast." And I thought, good question coming up now about the podcast. He said, "Can you give us an update on Monty, your Labrador?" We always do an update on Monty, usually under the desk when we're recording. So there you go. I'll thank those for us. But yeah, it's nice to be here. Nice to reconnect with Tricia. As we did a double act together at Confed, and obviously you've given evidence to my select committee relatively recently. Yes. I suppose anyone who does listen to said podcast would know that prevention and cancer are the two things that I get out of bed for. They're the pillars of what I want to do on the Select Committee. We're going to Singapore on Sunday as part of our future cancer inquiry, but it goes deeper than that. I mean, when I was in that role as a public health minister, and I wrote the Prevention Green Paper with Matt Hancock, who much maligned these days, unfairly actually, but was a fantastic boss to work for as a Secretary of State. Incredibly trusting in his ministers, and he really said to me, "Look, I think you know more about prevention than I do, so write the Prevention Green Paper," and he backed me 100%. So a lot of the ideas that were in that, it was a challenge, shall I say, in the Theresa May government with some of the ideas that was in that Prevention Green Paper. But a lot of that has sort of fed through, and we're seeing some of that now come to fruition. So, I guess what I would say is, I think the NHS in England is in some ways in a good shape. And I think in some ways it's in a very dangerous position. It's in a good shape because I think it's had the last structural reform, which is the creation of the integrated care systems, the ICBs. They came from the NHS. I don't think anybody is really arguing that we should turn the tables upside down in the temple. But I think it's in a dangerous position because it's it's increasing its budget faster than GDP, and demand is outstripping supply by a frightening level. And so we either make a decision as the country that we want to continue to increase its budget, and then make those sacrifices that Patricia remembers from around the cabinet table you have to make to do that. And I don't doubt that the budget will continue to creep up. But you ultimately you can't keep doing that forever, because your economy falls over. So you have to address the demand-supply dynamic and what's going wrong with that at the moment. So that's why we launched the prevention inquiry. It is massive. It has 10 different work streams to it. We have only done one of them completely so far, which is the vaccination report, which I hope you liked. Yes. We got the government response to that last week, and we'll publish that this afternoon. I'd give it they give it a 5 out of 10 in terms of their reply to us. And they'll be getting a letter back from me tomorrow about that. So the way I mean, other than clean water, highly topical for tragic reasons at the moment, but other than clean water, vaccination is the greatest preventative public health measure that we take, and we know that. So the reason why we're doing all the other things in the prevention inquiry is we did instead of doing a call for evidence, which select committees normally do, we did a call for proposals. So basically a call for ideas of things that we should do, and we had about 600 submissions, and but what ran through all of that was sort of inequalities, and I had to somehow boil that down into 10 work streams, of which vaccination was the first one we looked at. Healthy homes is what we're doing at the moment. We finished that off this morning. We had the King's Fund in this morning, among others, and we're going to be producing a report about how where we live, where we work, are major determinants of poor health. And so you should look out for that from us in the next few weeks. The other streams, just so you, for those who don't know, I'll just tell you. I mean, so health inequality will be one, mental health will be another, healthy eating and obesity, that agenda we will definitely return to, as we will smoking, drugs, alcohol and gambling, sexual health. I had an illuminating conversation about at the Pharmacy Show on Monday. Early years and childhood, we'll be doing a stream on that. Cancer prevention, which overlaps with the future cancer work, which is why we're going to Singapore next week, and then the other major conditions, so all those comorbidities. And then just finally, I suppose I would touch on, I've said this before, the way that I can think of our inquiries is that they are like the Olympic rings, in that they obviously exist as rings, but they interlock. So you can't really talk about the future of cancer without talking about prevention, which is why the Gallery trial, or Pinpoint, as another alternative of it, which for those who don't know, promises upstream pre-symptomatic detection of early stage cancers, could completely change the game in prevention and detection of cancer. So they interlock, and equally our pharmacy inquiry interlocks with prevention and with cancer. Our men's health inquiry, for very obvious reasons, overlaps with that. And we have a session next week with the committee when we'll be talking about what our future programme looks like next year, because if you don't think that's enough, which I don't, the clerks do, and they're exhausted by me constantly. I can't think why. But anyway, we'll be having a conversation next week about what we do in the new year, and it will continue to fit into those pillars of cancer and prevention. So I'm quite interested in doing something around eating disorders. I think it's a huge challenge post-COVID for a lot of girls and boys. So we'll be looking a little bit at that. And I think that's probably, there's lots of stuff I could talk about with Genomics England, who we had in recently on the Future Cancer Inquiry, but that's probably enough of a framing from me.
Fantastic, thank you so much. Would you like a microphone?
I think I will, probably. Thanks very much indeed, and it's such a pleasure to be here and to see some old friends and former colleagues, and looking forward to the discussion. But Steve, everything you have said about integrated care systems and about your amazing Select Committee inquiry on prevention, completely agree with your analysis of the situation. And when my report was published last year, and when you and I were at the Confed last year together, just as the government published its response to both our reports at that point, I said integrated care systems are here to stay. And it was a statement of ambition and faith, as well as a statement of what I believed to be reality. Today, it's reality. And it's really important because every one of us who works in or with the NHS knows that you have to work. You work with people, with governments, but also with local councillors and with people of all different political persuasions or none. And integrated care systems, because we're a partnership between the NHS and local government and social care providers and the voluntary and community sector, but particularly because of that local government element, again, by definition, you are working across party and therefore in a non-party fashion. And in fact, I was talking to one of your parliamentary colleagues this morning, one of our local Conservative MPs, about a tricky situation that we've got. And I'm saying to him, I so appreciated the way he was handling it as a constituency MP, thinking about my own experience. He was saying, I know, he said, I really confuse the Labour members locally who are campaigning on this particular issue because I tell them how wonderful you are. So, you know, just this cross-party, non-party alliance. And it's really important. And it's important for another reason, not just because it's a fact of life when you're working in local partnerships. One of the things I learned in government, I guess it's something you've all experienced, if you are going to make lasting change, you have to have support that goes beyond one political party and goes beyond the lifetime of one particular government. Something like the minimum wage, which was highly controversial and politically contested at the time, has become, like so many features of the post-war welfare state did for a very long time, a matter of bipartisan consensus. And so the more you can build that cross-party consensus as you go along, the more chance you have of reforms lasting and really taking root. That's why I did the ICS review at the invitation of Jeremy Hunt, to the dismay of some of my Labour friends and former colleagues, but that's fine, we've moved on. So on the prevention side, as Steve says, that was really at the heart of the review of integrated care systems, and it's at the heart of our work. Because if you look at the four core purposes of an integrated care system, they are to support the population to achieve better health and well-being, physical and mental, as well as to have better services. So better outcomes, tackling the gross health inequalities that we know exist in our country, a 20-year gap in healthy lifespan. Thirdly, getting the best value for money for the public pound, the Norfolk and Waveney pound in our case. We've all got to do that, nor more so, given the state of public finances after COVID, after Ukraine, and so on. And fourthly, of course, to support the NHS, our largest national employer, to play an even bigger role in economic and social development of local communities, bringing us neatly back to the wider determinants of health. So that is critical. But one of the things that I'm noticing really sharply around integrated care systems, but also in the national debate, is a recognition, much more so than a year ago, that if we carry on as we are now, and primarily that means if we carry on with almost all our focus and money and energy going into treating illness, and treating illness often at the most acute stage and in the most expensive part of the system, in other words, the acute hospitals, we will never have enough money, enough beds, enough hospitals, enough staff to care for a population that, of course, is increasingly older, increasingly unhealthy, and increasingly unequal. So that case for change, which I think was at the heart of your report and at the heart of my report, that is even more visible now as we go into an incredibly tough winter, where the pressures on the NHS, compounded of course by industrial action, the pressures on staff, turnover amongst staff, all the things we know about are even more visible than they were a year ago. So the case for change, the Burning Platform, is absolutely there. But what's also very noticeable over the last year, because statutory ICSs have only existed for about 15 months, is how rapidly they're developing. We all start, every ICS is different, you all know that, you've seen one. We're all different, and we're all starting from a different starting point, but we're all growing and maturing. And I say that as the chair of, sadly, one of the two most challenged systems in the country, Norfolk and Waveney, and whichever bit of the southwest it is, my colleagues down there. We are the ones who've got the most troubled trusts, the worst performance on ambulance delays, the worst performance on cancer, in our case, the worst performance on urgent and emergency care and elective recovery and. So we know that, but the point is we're doing things about it. So you can see and feel that maturity developing everywhere. And it was good to hear Helen Waitley Monday, at the, what was she doing, select committee? No, it wasn't your inquiry, it was another one. Anyway, somewhere she was in front of one of the committees. Refer rightly to the problem of management and leadership bandwidth. We are having to do so many difficult things simultaneously, including a 30% cut, too big and too fast, in the headcount of the ICBs themselves. And all of us need to reshape and get the right capabilities as well as the right number of people for our role, but it's one more demand and a very time-consuming and difficult one for all our staff, on top of everything else we're having to do. A final point I wanted to make is the other thing that is very visibly increasing in the last year is the work on prevention and population health management. And that is so exciting. A lot of that is absolutely, I was going to say driven, it's more, I think, informed and supported by really smart data analytics and population health management and digital stuff. So in my system alone, and we have 3 acute hospitals without an electronic patient record between them. So we're a digital desert when it comes to our acutes. It's a really big risk and challenge. We're in the process, just announced the procurement of a partner for that new EPR system. But in primary care, where we have a wealth of data, we have an absolutely leading system called Protect Norfolk and Waveney, grew out of something we did in COVID, where we are actively identifying through smart data analytics people at risk. We used it during COVID to manage about 25,000 shielded and vulnerable people, save lives, because we were in touch with them every day. We're now using the same approach, which is both high tech and high touch. There's a lot of human contact in this, to identify people who've got unmanaged type 2 diabetes or undiagnosed or close to being diagnosed or being visible type 2 diabetes. And it's having a dramatic effect on patient engagement and patient activation. We're using it, our county council is using AI to digitize and make machine readable all those very granular social work assessments of people who need domiciliary or residential care, and they're using it to predict falls, and then through human intervention in most cases to prevent a large number of those falls. So there's lots and lots of that stuff going on, and every system has its examples of that happening, some system-wide, some at different scales, it varies. But there's still a huge amount more to do, but again, I think more than enough for me to start, so we can come back to that in questions and discussion. Rebecca, do you?
Back to Rebecca.
Thanks, Patricia. Thank you. So, well, you've made the case already. I don't know. I'm not sure I really need to sort of add to that. And obviously echo much of what's been said by both. I think, from an industry view, of course, we want the best for our patients too. We think we do have some of the worst outcomes in Europe in many disease areas, so whether that's respiratory, oncology, in many areas. And of course, we have that common purpose of wanting to improve that. And very much recognise the picture that you painted, Patricia, in terms of the challenges in the NHS, whether that's workforce challenge or infrastructure, wait lists, whatever it might be. So clearly we need to create space to do something differently, and that obviously needs change in thinking. What could we do to sort of support that healthcare system? Perhaps moving more to prevention, as you say, because we can't keep doing what we're doing because we all know there's not enough money. And Steve, as you were saying around, we can't just keep pouring in. What could we do differently? So let's shift to prevention. So very much echo much of what's already been said. I'm going to add an additional angle as well, which is one around sort of productivity and health and well-being, and the link that's there. And I was absolutely shocked to learn that actually we lost in productivity in the UK around 150 billion a year, which is the entire cost of the NHS. So to me, so that, there is, as we all know, there's a link between health and well-being, but it's really that kind of call for a healthier nation is a wealthier nation. So that again makes another sort of significant case really for prevention, just adds another dimension, I think, to some of the things you've already been talking about. And just to add really from that, from an industry perspective, what are the things that could help do that in terms of make that capacity that you were talking about, in terms of freeing up that capacity to treat earlier. So obviously we have a lot of innovation in medicines happening, in vaccines and technologies, diagnostics, and all of those things can help to create that capacity, to create that sort of opportunity for focus on prevention, better outcomes. But actually in the UK, again, you may be surprised to learn that we actually have relatively low uptake versus our comparator countries. It's around half, just a little bit more than half of comparator countries in terms of uptake of new medicines. That raises to about 80% within 5 years, so it is relatively slow. With a slower uptake, of course, then we're having less access for patients to new medicines, and of course, are we really helping them to achieve those better outcomes by that delay? I'll talk a little bit about vaccination, if I may, as it's of course close to my heart, something we talked about in detail with your inquiry, Steve. And you'll know that it was very much we highlighted, and you heard from all the different experts there, that that we've historically in the UK been very proud of our world-leading approach to vaccines and our vaccination programme, but the coverage rates have been declining since 2016, and actually they continue to decline post-pandemic. So, what can we do? How can we make some of those interventions to sort of help, really change that and get back to where we'd like to be? And I'm really delighted and looking forward to seeing the response to the report. Very much supportive of the inquiries reports and some of the things it called for there in terms of how we might go about getting back to that world-leading position, whether it be in different vaccinators like pharmacists and other healthcare workers we talked about, or whether just different aspects to those opportunities. And of course we've got a great blueprint in the UK in terms of the pandemic response to how we could, and certainly as an industry, play our role in collaborating there. So we as an industry are very keen to do that, to play our part, to be a partner with the healthcare system. And I think it's a great example of saying, look what can be achieved when you've got common goals. We do share purpose, all of us. So we'd love that seat at the table to continue to work there and try and make this sort of system-wide approach to the change we'd like to see. And the government highlights through its life science strategy, the pandemic and response as a best practice, and that was all the way through from vaccine development, all the way through to delivery, innovation in clinical trials, innovation in regulation. So a really, really good blueprint, and I think the opportunity, as we've talked about before, not to lose that, so that we continue to learn from that. And of course, a world-leading vaccination programme could of course be a cornerstone of a prevention strategy for the UK. But of course, vaccination is just one angle. So obviously, as I say, something that's close to my heart in my role. But of course, screening, early diagnosis, appropriate evaluation and delivery of new vaccination, and early uptake of new medicines, nice approved medicines, you know, all things that can be done to help really create that capacity and improve patient outcomes. So I suppose I'll just go back to close by finishing with that sort of link between health and well-being. A recent report showed that we think there's about £18 billion on the table by increased productivity. So I think we'd all look for, you know, any support back to the economy as citizens of the UK. But actually, if we could, you know, if we can access some of that through some of these measures, many of the different themes already been discussed, then there's huge opportunity. And I think the ask from industry would be to be that partner with the healthcare system to help do that.
Microphone issue. Thank you so much, everyone, and a huge amount already in those opening remarks that we can draw on. I'm hoping that I can bring as many audience members into the discussion as possible, but I will steal the moment to ask a few questions of my own, and hopefully everyone will have some responses to these, but they're in some ways a little bit specific to particular people on the panel. One question I had to start maybe with you, Rebecca, was about the about early intervention and prevention as an innovation space. One of the challenges I think that we have in the system is that because a lot of the resource and budget sits with the kind of specialised acute end of the spectrum, that this doesn't look like a space which is as exciting to be an innovator in. Is there a way in which we can start to shift that in terms of the way in which industry approaches innovation?
So, well, I think there's many different themes in there. So I think in terms of, I think there's a lot of innovation actually, but I do think in the UK it's challenging to have that uptake in innovation, and I think there's challenges in the wider ecosystem, for example, to invest in the UK, and I think that's something that, you know, really as a country we need to make sure we sort of keep a sharp focus on. That's having, you know, really a thriving life science environment where companies can come and invest. I know the government's own targets at 2.4% of GDP to invest in R&D, I think I have that right. You know, how do we continue to make that happen so innovation stays in the UK? And I would sort of call out that currently it is a challenging environment. We have a voluntary payment scheme called VPAS, which is currently in negotiation with the government at the moment. It's very high rates. It's currently we pay something like 26.5% this year versus normal background rates of around 6 to 7%. So when you have that huge sort of rebate on top, we have a reduction in clinical trials, which again we've talked about other pieces, a drop of something like 41% clinical trials conducted in the UK since 2017. I mean, those are all things that we need to sort of overcome to allow us to continue to sort of be that partner innovator in the UK.
If other panels have comments on that, if not, I will jump into some other questions.
No, keep moving, continue.
Fantastic. Question I was going to ask to you, Steve, in particular, and I think Patricia mentioned this about the need for cross-party consensus here, and this kind of stickability of the prevention agenda being reliant on it being a kind of consensus issue. One of the other questions I was going to ask is about this being a cross-government approach. I know as part of the select committee's terms of reference and your inquiries are very much about working with other select committees and working across Parliament to consider this, but how do you think we can best develop a kind of joined up cross-government approach to prevention rather than seeing this as being the Department for Health's responsibility and everyone else playing second fiddle?
Well, it's not the Department of Health's responsibility, and Patricia will know this better than I as former Secretary of State, is that if you look at those 10 work streams that I talked about, barely any of them have got responsibility laying in the department. So it can
vaccination, possibly.
Yeah, it can be owned, it has to be owned by the centre, and it has to be owned by number 10. So, you know, it is no secret that I spent quite a lot of time talking to number 10 in recent weeks, trying to ensure that the smoking policy stayed in the conference speech. because we deal with politics as your government dealt with politics. The original smoking ban had a lot of politics around it, right? There's a lot of challenges within the labour movement, wasn't there, around working clubs, etc., etc. We deal with those politics too, and prime ministers are always constrained by politics, and there was obviously a concern about the banning things of the smoking ban. But in the end, I said to him, look, if you're going to run on the slogan of long-term decisions at conference, you probably won't find a better long-term decision than what you propose on smoking. You will save a lot of lives, and so he owned it, because his view is that you can't smoke in moderation. Whereas there's a slightly different, more nuanced argument around obesity. So they're seized of the positive response they've had to that. Other than she, who we don't speak of, everybody else seems to be positive. I can't wait to hear the argument against lung cancer in the debate on it. But everybody else on the right of my party is pretty seized of this policy. So number 10 are taken with that, and I've tried to explain to them that actually in a publicly funded health system you have a right and indeed a responsibility to act on public health, because it is a publicly funded health system. And this comes of course from the state that recently made you stay in your homes by order of the state. So don't give me nanny state bullshit anymore, frankly. So I'm trying to talk to them about where they go next with this prevention agenda, because what governments, number 10 like to tick boxes. They like to think, done that bit, and they are not going to turn the prevention agenda. They're not going to seize the prevention agenda by this smoking policy. They are going to have to move wider. So it has to be owned at the centre. To give you an example, this morning when we were talking about healthy homes, there's this thing called the NHS England's Healthy New Towns programme. And if you think about the NHS, so integrated care systems, they would be statutory consultees on new development, on big new towns. Keir Starmer's talking about new towns, so the NHS will be statutory consultees on that. But they generally, we were hearing this morning in evidence, they generally tend to basically just talk about NHS facilities.
Yeah,
they
GP
don't.
Surgery.
Yes, when's the surgery coming into the home? What they don't really talk about, and they should talk about, is how do we build developments that encourage good health. And that's the thing. So there's a classic example of something which is clearly not the Department of Health. I was talking in the House yesterday about the Healthy Homes Amendment that Lord Crisp had put down with Dave Blunkett in the Lords and George Young, who used to be the Tory Chief Whip. And that was to the Levelling Up Bill, which is clear. Is that department DEFRA own air quality with the Department of Health? So it has to be owned at the centre. It has to be owned by the Prime Minister. We all know, as whether you're a Secretary of State or a public health minister at the PUS level, the fact is if number 10 don't want you to do it, you're not going to do it. Yeah, it never happen. It never happen. So.
Can I just add to that one? Thanks. Congratulations on the smoking announcement. I should have said so, Steve, because that was brilliant. That is the real radical leading edge of what's happening around the world. And it was great to see it announced, I think immediately endorsed by Labour, who probably said they'd thought of it months ago and announced it, whatever. But it will happen. And that's absolutely brilliant. It's really important. But the thing, Steve and I are in exactly the same place on this, because what we recommended in my review was a national, let's call it the national mission, to improve the health of the nation, with a cross-government cabinet committee chaired by the Prime Minister and cross-departmental working. Because without that, you cannot get things done. You absolutely have to have number 10 and the Prime Minister, but you also have to have machinery of government stuff underneath it. And I don't know if any of you are machinery of government nerds, and we don't want to spend too much time on that. But when I became Trade and Industry Secretary, and I discovered I knew my department were going to do a white paper on broadband and stuff, digital stuff. Then I discovered Department of Culture were going to do a green paper on broadcasting. And so I just got hold of Chris Smith, who was Secretary of State for Culture, and I said, this is bonkers. And he said, yes, of course it is, because it's all the same thing. Because broadcasting and broadband were all converging. And out of that eventually came Ofcom, because we had 9 different regulators at that point. But the critical thing was we said, right, we will have one team of officials working to one team of ministers. Next thing that happened was the 2 permanent secretaries had a massive argument. It was kind of, right, we're in charge, you can send your officials over to me. No, we're in charge, you can send them. So my private secretary told me this, and I said, right, just would you let the permanent secretary know that if they carry on like this, they will sit in a porter cabin in St James's Park, right? One team, I don't care where they're located, one team and one set of advice from the integrated team to ministers in both departments. And if they disagree, that's fine, but tell us. Don't bring the war up to the ministers in an unhelpful way. And that's what you need, because this healthy homes piece, the NHS doesn't know about healthy homes and developing livable cities, but there are masses of people locally, nationally and globally who do. And we need that expertise.
That leads me on actually quite nicely to the final question I have before I open it up to the audience, which is about the system level. I think a lot of the conversations we have about things like even industry partnership, but partnership in general are very much either kind of national or at a kind of trust provider level. I am a bit of a machinery of government, but particularly an ICS machinery fanatic.
Yes.
Very interested in whether or not we've kind of got the structures right there, both in order to facilitate cooperation with business and industry, but also to really shift the dial on the determinants of health. I mean, one stat that's often quoted here is that 80% of health has nothing to do with healthcare, but it seems that within integrated care systems, that systems are very much reliant on their acute trust partners, as opposed to being true partnerships of equals. So wondering from all of the panelists about how we get that mix right at the system level.
Trying to crack. Yeah. Look, we all get, I think, and increasingly even the acute trust leaders get, that health doesn't depend on what is done inside the hospital. Very little of it does. Brilliant and life-saving and all the rest of it, though it is, on occasion. But you don't fix that problem by having yet another round of structural reorganisation. And the institutional landscape that we've got for integrated care systems is complicated. You know, statutory integrated care partnership, convening all the partners within that. A key partner is the integrated care board, accountable for the whole performance and finances of the NHS, and within that you've got foundation trusts and all the rest of it. So it is complex, but it reflects a complex reality. The real challenge is how we shift the focus, the centre of gravity, and some of the resource away from the acutes and into much earlier stage prevention and intervention, in which, I mean, thinking about older people, you know, what we are moving towards in our system, and a lot of systems are, is essentially recognising that for older people, an emergency admission to hospital is a harm event. It should be avoided at all costs. The goal should be 0 emergency admissions for older people, right? As one of the large goals. And then what do you have to do to make that happen? A whole bunch of things. And that includes a different role for the geriatricians and some of the other specialists who will go on being employed by the acutes, but work in a very different way and sometimes a different place. So I think that is understood, and as I say, it doesn't require further changes to the structure. I think your point about the industry relationship is a really interesting one. So our system is one of, I think we are leaders in this. We've got quite a lot going on at a system level with some key private sector partners. So for instance, on virtual wards, or with NHS shared business services transforming back office across all our providers, not just one by one. And you know, there's some other examples like that as well. But what I think is very difficult for innovative companies, whether they're, even when they're quite large established companies, and much more difficult if they're small startups, you know, if you've got a great way of doing teledermatology, which absolutely is critical to sorting the waiting lists. Dermatology is, you know, one of the biggest contributors. Nightmare if you're at high risk of skin cancer, which I am, being Australian. You know, it's a real problem. Trying to make those changes, even 42 systems one at a time, never mind 100 and however many trusts one at a time, is very difficult. I think there is scope for a small number of national contracts, probably with you'd have more than one provider, you know, you'd do a regional carve-up or something, for some pathway transformation that's digitally and medtech enabled, but it's got to be used really carefully, because the other thing there's a growing recognition about is we've got a far too centralised system. It's all that micromanagement and vertical silos and everything else that, again, were at the heart of both Steve's and my reports last year. But so that is a real problem, and you know, you can't have every bit of industry sitting around every one of the 42 ICBs. The academic health science networks are part of the answer to that, but there isn't a perfect answer to that one, I'm afraid.
You might pass over back to Rebecca, and then I will open it up to the floor.
Yeah, sorry.
Thank you. So yes, very much so. And actually Sanofi works on a number, I think we have around 19 different collaborative working projects at the moment, actually very much talking about the things that you were talking about, particularly in areas like trying to improve patient pathways to care, dermatology, as you're saying, being a massive challenge where the lack of capacity in the systems, meaning the later diagnosis, for example, exactly as you mentioned. And those are some of the areas where, as an organisation, Sanofi are working at a local level to work in that partnership. Now, you know, very much the opportunity to sort of learn from those and share those best practices, and then, as you say, then it's scaling up, isn't it? And how are those shared across more widely? We're of course recognising that you can't do everything and you have to pick and choose, but those are the sorts of opportunities that actively we are working on, making some progress, and you know, it's, you know, for better patient outcomes, you know, industry in partnership with those
higher
businesses.
productivity.
Indeed.
There are quite enough consultants if we use them properly.
So, indeed. So that's you know, that's absolutely you know, one area, and of course that also supports that reduction in inequalities as well, which is seen across the system. So masses of opportunity, which we're keen to continue that collaboration on, and continue in other geographies. And I suppose on a slightly different level, not talking just about ICSs, because we talked about system-wide in general, perhaps on a more macro level, I guess the industry feedback, maybe I could say, would be it's so complicated, it's hugely complex, knowing how to engage with the right stakeholders in the system, the right time to have the impact. You know, I think in vaccines, again, particularly with the department, with AXA, with the JCVI and the sort of ongoing discussions there. So, you know, I think it's all good opportunity to sort of continuing figuring out, you know, best practice and how we move these areas forward in collaboration and partnership.
I'm going to open up to questions from the floor. There's already been a few hands up. I'm going to take them in threes. If people could make sure that the questions are short, just so that we can get through as many as possible. I can take them all over here.
Hi, I'm Alicia Weston from an organisation called Bags of Taste. We work with people with multiple deprivation to improve their diet. And I'd like to pick up on the health inequalities thing, because they're very highly diet linked. And just to give you a stat, the bottom 10% of society eats 7 times more takeaways than the top 10% of society. So if you want to deal with this, and it comes across lots and lots of your work streams that you mentioned there, Steve. So diet affects mental health, it affects long-term conditions, because a lot of them are diet related, but particularly diabetes is an entry level for multiple long-term conditions. And and also it's the leading cause of cancer in this country, is obesity now.
You
So
said it's called bags of taste.
bags of taste.
Love it.
Thank
Great
you.
title.
Or something like HelloFresh with added motivation. So I just, there's been a complete mess of the obesity strategy, right? Everything got rolled back, and can you give us some insight into what is going to, what you hope might happen there? Because I'm pretty dispirited at the moment.
Okay.
Come over here, and then to the front row here.
Chris Smythe from The Times. I just want to ask about the finances point in two parts. One is, no one doubts the importance of prevention, but the assumption that it will save money in the longer term is questionable, given so much of the cost is towards the end of life, and you die something eventually. How convinced are we, and what evidence is there that this shift to prevention will actually save money? And related to that, obviously, how do you ensure that you get the resources into these preventative health services, let alone all those upstream things that fundamentally influence our health, when the practical and political imperative is always to suck money into hospitals to deal with the winter A&E crisis?
And then a final one over here at the front.
Hi there, James Owen from Health Service Journal. A question for Patricia. You mentioned the kind of centralising issues around NHS England. A lot of our readers have been saying that actually since your review came out, if anything, intervention from the centre has actually got worse, not better. You've obviously got your frontline experience as well as a very kind of good national view on it as well. I was just wondering, first of all, is that an analysis that you'd agree with, and also what examples there's been of it and what you'd like to see done about it?
I think I might go along the line for responses to all three of those questions. So first to Steve.
Yeah, well, we can't all answer them all, otherwise we're going to have to vote soon, I'm afraid. Very soon by the looks of it. If I do the obesity, so I wrote the chapter 2 of the child obesity strategy, and there were various things in there, some of which, obviously the sugary drinks industry levy was in part 1, which I brought in, and then there's lots of things in part 2, Pathfinder studies around unhealthy food near schools, the Daily Mile, Healthy Start scheme. If you're talking about stuff like the advertising restrictions, the post 9 PM watershed, and that stuff, I think that is stuck in politics right now, is the honest truth. I don't think you should have much expectation to see any movement on that this side of an election. I just don't think that the government have the political space in which to move back into that. It doesn't mean that I won't continue to make the argument. It doesn't mean I didn't have a letter from Diabetes UK's acting chief executive just last week, which we published this afternoon, talking about the rise in obesity rates and what that impact that has on type 2. But my honest expectation is that I wouldn't expect to see a return to that agenda in the policy sense this side of an election. It is in a way linked to the Times question. I mean, if smoking related illnesses cost the NHS in England 17 billion quid a year, and if diabetes costs the NHS budget about 10% of its budget, then I think it just speaks to common sense that acting on those two alone would actually save a lot of money and reduce demand on the system. If you were to roll out, if the Gallery trial proves successful, as I think it will, you were to roll that out at scale, you would pick up a lot more cancers at stage 1 instead of stage 3. You would save an absolute fortune on cancer treatment and cancer drugs, and my dad wouldn't have been diagnosed with pancreatic cancer at stage 3 and be dead within 3 months, because we don't pick up pancreatic cancer at stage 1 unless you're extremely lucky and having ultrasound on your pancreas for some other reason, and they spot a tumour and they whipple surgery it out. So I think it goes it speaks to common sense that it will save the NHS money, because it will save the NHS demand. You may wish to answer the point about the system, which you're best placed to answer, not me.
Indeed, and Steve endorsed that. But I'm not going to try and come back to Leisha's point because there simply isn't time, unfortunately. But Chris, on your point, I think it's really important for people to distinguish between the real benefits that are achieved by shifting upstream to more effective prevention, earlier detection, earlier intervention, and more support for self-management of long-term conditions, and cash releasing savings, because the two things don't always match. And at the moment, we all know that there are many people in hospital who shouldn't be there. And if they've got the right care and support, probably earlier, but certainly in a different part of the system, then they would not have been in hospital. But that doesn't mean that those beds aren't needed, because we've got lots of people on the waiting list who do need treatment in those beds pretty quickly. So, you know, government as a whole, as well as systems, have to face up to that. And the one point that I would add to what Steve has said on that is we need the Treasury to understand the economic benefits. Rebecca was making the point, the economic benefits and the productivity benefits of a healthier population. I think it's something the Chancellor has made, you know, really important statements about. But we need to understand that, because the benefits of prevention and earlier intervention won't always flow into or back into the coffers of a individual part of the NHS or the integrated care system or NHS England.
Yeah. And said Chancellor will be on my podcast next week.
I shall listen with
talking
great
about
interest.
he's coming in on Tuesday
But
to record
in order
on
to
exactly
make
this.
the shift,
prevention.
in order to make the shift, we need the local action. So again, all around the country, you can see local government, the NHS, through the ICBs and primary care and the voluntary sector, all working together. You've got to go and vote.
I'm going to go and vote.
Yep, otherwise you'll turn into a
Minister
content, and
on
we
his
can't
feet.
have that.
You remember that message?
I know that feeling.
God bless. Thank you for having me, everyone.
Bless
I'm
you.
going to have to go and vote. Sorry.
Look forward to seeing you soon.
Thanks. I'll see you soon.
So you have to have the local action, and there's example after example of, as I say, local government, the local NHS, ICB, primary care, whoever, and local voluntary and community groups working together, pooling resources, targeting their most vulnerable population, using data analytics to do it, and getting better results and keeping people safer, better, solving wider problems for them. James, on your, it was James, wasn't it? Yes, sorry, there you are. On your point about centralising, I don't think those criticisms are really fair, although I understand why people are making them. The pressure on the system is reflected in the pressure on government ministers to get results, because the public, quite rightly, want results. We've just heard about Steve and his dad, and we've all got those stories. So the public want to be able to, you know, see their GP or somebody else in primary care. They want to get their diagnosis, they want to get their treatments faster than too many people are getting them at the moment, and not enough people are getting at the moment. And so that pressure, particularly in the months or 12 months, however long, leading up to an election, is reflected in pressure from the Prime Minister in number 10, from health ministers, from NHS England, from everybody. And it's very understandable. Sometimes it results, as my review described, in multiple demands for data, multiple demands for meetings, multiple demands for this, that, and the other, that actually reduce the ability of system leaders and those at the front line to solve the problems. And therefore, you know, all of us have to be able to have those honest conversations where we say, we're all agreed on the problem, we all know why there's a problem, we can all see what the answer is. So just give us a bit of space to get on with solving the problem, right? Because if we spend all our time in meetings telling you what we're doing or filling in data forms for you, we won't actually solve the problem. So, but it's an understandable situation, and it's not caused by NHS England. On the more positive note, have a look at what NHS England has done on the ICB governance review. A year ago, that would have been a massive, unreadable wodge of guidance with an extensive tick box template for us to fill in and then have our homework marked. And it isn't that. It's been a really good process of co-design with systems, giving us a tool that we can use when we want to solve problems that we have identified with our partners in the system. Absolute model of the new way of working. It's really good. I think, I was going to say this while Steve was here, I know that NHS England's new vaccination strategy, which should be out quite soon, has also been developed very closely with ICBs and wider colleagues, and I think will say quite a lot, and will have ICSs at its heart in terms of local delivery, particularly to marginalised and underserved groups. So again, that is very different, and certainly in the east of England, we're finding a very different relationship with our regional director and team, which I think is very positive. So, sorry about that, but on the other hand, it is on the record. So.
We are a little bit out of time, but I'm going to pass it to Rebecca for final comments before bringing the session to a close.
Well, so I suppose the main question, or go back to your big questions in terms of the financial piece, which was, we know that late diagnosis not only results in worse patient outcomes, but results in more cost, because you end up often using more costly sort of end of treatment medicines, and that cost. So clearly there's an opportunity there. There's also the productivity piece. The healthy nation is a more productive and wealthy nation that that we commented on earlier. And I think the last piece, I suppose, is around, we all know that there is a winter crisis coming. It's almost like an all-year-round crisis now. There are opportunities to, prevent some of those hospitalizations through innovation, whether it's in vaccination or other medicines, and actually finding the space to use them at the right time, I think, can help the total sort of healthcare system and benefits.
We are out of time. I'd like to say sorry for not getting through everyone's questions, but it is always the way with these kind of events. And say thank you to all of you for coming along today. I've really enjoyed chairing this session. We at Reform are currently undertaking a program of work on reimagining health, for which prevention and health creation are right at the heart of. So if you do have further thoughts on the subject or want to come and talk to us, please do find me afterwards, and there will be opportunity afterwards for some refreshments and networking. So please do join us. Thank you so much for coming.